Ladies and gentlemen, thank you very much for attending the episode 2024, the Center of Hepatology. Now we would like to start our conference program. Now we start the next session, chaired by Keisuke Tateishi, Osamu Yokosuka. Please start the session.
Good morning, everyone. I'm Keisuke Tateishi, St. Mariana Hospital, University Hospital. So, time to start of the state of the art lecture. The speaker is Professor Tatsuhiro Shibata from Tokyo University. So, Professor Shibata is a very famous researcher, so always leading the genomic research in Japan. I'm looking forward to this lecture. Please,
Okay.
Professor.
Thank you very much, Dr. Tateishi, Professor Tateishi, for kind introduction. So, good morning, everyone. So, thank you for coming for early morning. So, today, in state of art sessions, I would like to briefly introduce liquid biopsy about DNA cancer diagnosis. Especially, I'm focused on epigenetic analysis. So, I have no COI. So, as you know, the epigenetics is a very important mechanism to regulate the gene expression in cell. And there is two types of epigenetic features which are associated with DNA regulation, RNA expression regulations. So one is modification of DNA. It is well known as the DNA methylation is a very important feature of this kind of modifications, or status of chromatin. So as you know that when gene is expressed, some transcription factors have to bind the DNA around the genes. So that's why the chromatin should be opened, and it's many proteins associated with this DNA. So in addition to the DNA methylations, the status of chromatin, such as open or closed status, is very important factors to determine the status, the epigenetic status of the DNA. So today I'll introduce two topics. One is cell-free tumor DNA methylation analysis, and the last part I'll discuss about the ctDNA fragmentomics. So methylation analysis of today I'm talking about cell-free or circulating tumor DNA, ctDNA. Do you know that ctDNA is derived from the cancer cells, which is by that apoptosis or necrosis or such kind of secretions. So the DNA is extracted, derived from these tumor cells circulating in the blood in human body, and using this blood, you can extract the DNA from the blood, and then sometimes people analyze DNA mutations in using the ctDNA, but today I'm talking about the methylation analysis of ctDNA. So using these circulating tumor DNA, you can analyze a different type of methods to analyze the methylation status of the circulating tumor DNAs, such as enrichment analysis or bisulfite-based sequencing. So if you use enrichment analysis, you can pull down the methylated DNA by using antibody or some kind of proteins, and then using this enriched DNA for the analysis. Or you can directly sequencing the methylated DNA by bisulfite conversions. So as I said, this is an example of enriched-based methylation DNA analysis of the methylated DNA from the circulating tumor DNA. So one is using the antibodies, which is specifically recognize the methylated DNA. So you can pull down the methylated DNA by antibody, and then using these enriched DNA, you can do the sequencing, or maybe you can analyze by array analysis. Or there is several proteins which specifically bind the mutated DNA. These are called MBD, mutated binding domain proteins. So using these proteins, you can pull down the mutated DNA and then using them to analysis. So bisulfite conversion is a kind of chemical conversion of the mutated DNA to a specific different nucleotide, and then you can analyze directly by sequencing. Anyway, using different methods, you can anyway know which part of the DNA is mutated in the tumor by using the ctDNA analysis. And there is one study which tried to detect the early stage of HCC by this kind of ctDNA mutation analysis. So first, this study tried to using the tumor surgical specimen of the HCC, they try to analyze which mutation loci is specifically detected in tumor cells compared to the normal liver. And then they found that the 38 mutation loci is very useful or very specific for the cancer compared to the normal livers, or maybe cirrhotic status of the liver. And then using these mutation loci, they try to analyze these 36 loci in the circulating tumor DNA. And then using these markers, they try to diagnose this early stage of liver cancer. And then they performed several different cohorts to validate this efficacy of these mutation markers. And it is not perfect, but this analysis shows that the mutation markers using by the blood is also very useful to detect the early stage of HCC. So there is also we know that several biomarkers for HCC, such as AFP or other protein markers. So there is a current trend to combine these DNA mutation markers and protein markers, or maybe DNA markers, such as, for example, P53 or beta-catenin or HB virus, using the circulating tumor DNA, and then combine this kind of multi-omics analysis, markers for the diagnosis. So, and also it is very important to know that each cell type has different epigenetic status. For example, liver and lung or stomach has a different epigenetic status because they are different cells, different type of cells. So using this kind of epigenetic markers, you can predict which is a primary site of these cancers. For example, if you have some cases which is you don't know which is origin of cancer, using a blood epigenetic data, you may determine that this cancer is probably from the liver, or this cancer is probably lung cancer. So it's kind of prediction of primary cancer site. This study shows that the same specific mutation markers can determine that discriminate the different tumor types. And also, using this based on these data, there is a large-scale cohort analysis using the early cancer diagnosis by the cell-free DNA mutation status analysis. So this is called the circulating cell genome atlas, CCGA. And they analyze about 7,000 samples, about 2,400 cancer and 4,200 normal people, and they try to they analyze the maturation status of the blood circulating tumor DNA, and they try to discriminate the cancer from normal patient, and also they try to detect which is primary site. So this is data, and they show that even in the very early stage, stage 1, they can detect cancers using the cell-free DNA, and also they can evaluate the tumor type based on the ctDNA mutation and data. So it is very promising to using these technologies for the cancer screening. And actually, there is also a prospective cohort study recently reported, which is called the Pathfinder test. So they also analyze 6,000 cases, and using this cohort, they follow the patient, and they try to detect, try to analyze, try to determine this ctDNA mutation can detect the early cancers. And indeed, this is positive value is 38%, but very high specificity, 99%. And also, this mutation data analysis can detect such, for example, breast cancer or some biliary tract cancers or pancreatic cancers. So this mutation analysis is also very useful, could be very useful early detection of cancers. So this is my first talk about the ctDNA mutation analysis, and lastly I'll talk about the ctDNA fragmentomics. So it is not much well known about fragmentomics. So this analysis is focusing on the fragment end or fragment size of circular DNA, circulating tumor DNA. Because as you know, the tumor, as I said, circulating tumor DNA was derived from the cancer cells, which is, for example, apoptotic or necrotic cells. But in blood, this tumor is digested by the specific enzyme, because there is some enzyme which specifically target these free DNA. And but if you have the chromatin, for example, a histone is binded to this DNA, it is resistant to the DNA digestion because chromatin is tightly packed, and DNAs cannot access to this chromatin. So that's why the size distribution of the cell-free DNA is, for example, this kind of peak, which is consistent with the size of chromatin, because enzyme can digest between these chromatins, but cannot easily digest these histone-associated regions. That's why there is specific size which is enriched in the cell-free DNA. And also, as I said in the first slide, DNA status, for example, open chromatin or closed chromatin is tightly associated with gene expression and also associated with specific cell type. That's why this open chromatin is easily accessed by the DNAs, which digest the DNA, but closed chromatin is resistant to the DNA digestion. That's why, based on this analysis, we can detect which part of DNA is easily accessed by DNAs and which part of DNA is resistant to the digestion. Then, you can speculate or you can analyze which part is open chromatin and which part is closed chromatin in the genome. So using these data, we can speculate the cell type based on the DNA size, DNA digested distributions in the genomes. So this is very important landmark studies. They analyze the fragmentation pattern of ctDNA in various type of cancer patients. And as you see that this is a healthy sample, and this is pediatric cancer, breast cancer, colorectal cancer, so different tumor type. And this is from chromosome 1 to chromosome 22. And you see this is a fragment ratio. And then, as you see that the different tumor cancer patient has a different pattern of the fragmentation of the cell-free DNA. That's why using these fragment patterns, you can also speculate what is a primary cancer of this patient, and also you can detect. You can use this data for more different way. For example, because this fragment pattern is associated with chromatin status. Chromatin status associated with gene expression. That's why using this fragment data, you can infer the gene expression based on the DNA, just the DNA fragmentations. So this is a study to using these fragmentation data to speculate the promoter activity of each genes. And also, this is an example of prostate cancer, but using this fragment analysis, they can speculate the androgen receptor expression, just the DNA fragment data. Because it is very difficult to infer the gene expression from the tumor cells, because it is sometimes very difficult to access. But using blood samples or liquid biopsy, you can now speculate the gene expression. That's why this is another data. So they also detect the histological change, because sometimes prostate cancer move to the adenocarcinoma to the small cell carcinoma. It is change of the histological type. But using the ctDNA fragment data, you can detect this kind of histological change. So this is very new ways to using the ctDNA, because previously you can only detect the DNA markers for the detection of the cancer, but now using these informations, you can speculate what kind of gene is expressed in the cancer and what kind of histological type these cancers. So it is more enriched data is available from blood. So this is my final slide. This is a future direction of the ctDNA genetics. So currently, using the DNA data, for example, mutation of the ctDNA in the cell-free DNA, you can detect the driver mutations, or you can monitoring the resistant mutations, or it is very also important for the minimal residual disease by using DNA. But now, as I presented today, epigenetic information is also very important and enriched because using epigenetic status, epigenetic analysis of ctDNA, you can predict the gene expression, or you can predict the subtype or histology of tumor cells, or primary cytic prediction. So combine these gene expression data, you can do the more refined personalized medicines, and also early diagnosis or cancer screening is also available. And currently, the ctDNA analysis moving from the genetic information onto the epigenetic information. And probably in future, combining the genetic and epigenetic analysis of ctDNA is very important diagnostic tools for the cancer patient, including the liver cancer or biliary tract cancers. Okay, so that's it. Thank you very much for your coming.
Thank you, Professor Shibata. So he proposed a big possibility of liquid biopsy using epigenetic status and combined with genomic information. So any question or comment from, okay, please.
Thank you.
Yeah, I'm Dian from Vietnam. So thank you for your interesting presentation. It's really informative and interesting. But just a quick wondering, maybe a little bit fancy, but now about we more and more interested in the circadian system, and in Asian traditional medicine, we care about the time in the day that the organ is active at its peak. For example, the liver is like from 1 to 3 a.m. So how do you think about the time in the day that we take the sample to do the, for example, epigenomics thing that we may have higher chance to detect the level in early stage or something like that?
Yeah, thank you very much. That's a very important question. Actually, it is known that the circulating tumor DNA is very unstable. So it's rapidly degraded and disappear. So it is good because using this analysis, you can analyze a very recent status of cancers. But is a question about the liver cancer or specific?
No, my point is the liver is according to traditional medicine, it's more active. From 1 a.m. to 3 a.m., for example. So whether if we take the sample during that day, maybe whether it can increase the chance that we can detect the marker of the liver cancer.
I see.
Using your method, for example. I don't know.
I have no data, so I don't know which timing is very important. But probably you can try your cases to see any different monitoring of different sampling and to check which is best. Actually, I don't have data, so.
Maybe do you have any prediction or something like that from your expertise? It's okay.
Okay, thank you.
Thank you.
Good morning, Jingling Ho from China.
Yes?
I think it's a very nice talk. One of the area currently, we are working on how to identify the pre-emerging stage for different kind of cancer, particularly in our region, HCC.
Yeah.
So how to combine multi-omics to define some very, very early stage of HCC. Thank you.
Yeah, thank you very much. Yeah, so that is very important, question. And actually, there is only very few papers published. So currently, I guess many researchers now focusing on these your questions, because we don't know good markers for the early cancer detections, even in very small liver cancer or very early stage. So currently, there is some papers showing that the combination of the epigenetic markers and probably early driver mutations such as the TAT promoter mutations or TP53 mutations, probably this combination could be better compared to the single markers, but there's no consensus and still in a research status, I guess.
Thank you.
Thank you very much.
Thank you.
I'm Dai Tai from Taiwan, Changde University.
Yeah.
We do a small series I think the Professor Ho has mentioned what kind of combination is important, but probably the number of genes we detect probably also important, because the tumor may have secret many types of fragment. The number of fragments probably also important. Thank you.
Okay, thank you very much. Yeah, I agree.
Sorry, New from Sydney. I just want a simple question: is what sort of volume of blood do you need for your studies? So how many millimeters? How many mils of blood?
Yeah, usually I guess 5 milliliters. Yeah, using one else. But it depends on the cases, but routinely, if you take 5 milliliters, it is enough. You can extract enough DNA for analysis.
So can you expect a shower of all these ctDNAs during intervention, like surgery or biopsy, that sort of thing?
Please say it again.
Yeah, during surgery or biopsy, do you expect a sort of shower of the circulating DNA in the blood? Let's say if the tumor is being cut or damaged in some way.
In such cases, you can the DNA, the circular tumor DNA should be increased. So you can highly probability to detect this tumor-specific DNA in the blood.
Okay, thank you.
Any question? Oh, okay.
Sorry, very quick one. Is there a limit to the size of tumor that you can determine that the DNA is in the blood?
Thank you very much. That is also very important. And theoretically, as you say, that the number of cancer cells is very important factor for the detection sensitivities. So there is no criteria of how many cells is minimum required. But as we expect that if you have very small number of cancer cells, sometimes it is very difficult to detect by this kind of liquid biopsies.
Any questions? Okay, thank you. So your talk is very impressive. So ctDNA methylation and fragmental mix. So tell us the etiology of the cancers. That sometimes, for example, biliary cancer, different primary site, extra or intrahepatic, maybe different primary site shows a different futures. This method is very big information for us to diagnose and treat the biliary or liver cancers. So impressive for us.
Okay, thank you. Thank you very much. As you said that, this epigenetic analysis is very promising.
Yes.
To infer the different tumor differentiation or tumor histology. So it is very exciting, I guess. So not much paper is published, but currently many groups are analyzing this using the technology for the biliary tract cancers or liver cancers, I guess.
Okay, thank you for great talk. So please praise again, Professor Shibata. Thank you so much.
Good morning. Next state-of-art lecture is by Professor Jinlin Hao. And he is now a professor of Department of Infectious Disease, Nanfeng Hospital, Southern Medical University in Ganzhou, China. Okay. He has published more than 500 articles, including Gut, Journal Hepatology, Nature Medicine, and New England Journal of Medicine and Science et al. And he was studied Department of Medicine of Nanfeng Hospital. And then he studied in St. Mary's Hospital in London between 1993 and 94. And then after that, also between 2000 and 2001, he was a visiting fellow at the Institute of Hepatology in London. And he was president of APASU 2017 and president of Chinese Medical Association for Infectious Disease between 2013 to 2016. And he's going to talk about getting to zero mother-to-child transmission of HBV, SHIELD program. Professor Hao, please.
Thank you very much, Professor Yokosuka, for your kind introduction. Good morning, ladies and gentlemen. My topic will be spend more time for preventing mother-to-child transmission of HBV infection. Currently, we are working on two areas. One is how to blocking mother-to-child transmission of HBV infection. The other is how to reduce the occurrence of HCC, as previous speaker just mentioned by liquid biopsy. I think it is very useful platform. In May 2016, WHO released the Global Health Sector Strategy on viral hepatitis, which set up the goal to eliminating hepatitis as a public health threat by 2030. During Easter meeting held in Barcelona 2016, WHO organized events, invited the chairman of four societies to sign a joint declaration for elimination of viral hepatitis. When I was president of PASO, targets for reducing new cases and deaths from chronic viral hepatitis B and C infection is very important in our region, Asia-Pacific area. From this target, we need to reduce new incidence of HBV, HCV, new infection by 19% by 2013. The other target is to reduce hepatitis-related deaths by 65%. We would like to take China as an example. China accounts for nearly 1/3 of worldwide HBV infection, around 70 million of HBV infection. Currently, Chinese Medical Society for Hepatology just updated their guidelines. They hope next stage will treat all HBV patients with detectable HBV DNA over 30 years old. The other important issue in China, we estimated the number of perinatal HBV transmission used to be very high, now gradually declined. We will have a look about 23 million women of reproductive age are possible for hepatitis B surface antigen positive. There are about half to 1 million HBV infected pregnant women annually, might be resulting in a lot of new cases of HBV infection. In 2017, Professor Eileen Wang reported annually new babies infected with around 50,000 new cases. So how do we get to elimination? Targets for scale up for prevent mother-to-child transmission. Definitely, I think the birth dose vaccination coverage is fundamental. We hope to globally, from baseline around 38%, gradually increase to 50 by 2020, 2030 to over 90%. Here we will have a look with the universal vaccination program. The prevalence of HBsAg in China used to be very high, over 10% in general population. Since 1992, this prevalence rate has gradually declined to nationwide epidemiological survey 1992 compared to 2006 blue line, 2014 is the green line. You will see currently the prevalence rate in young children younger than 5 years old is around 0.72% in general population. Vaccination coverage is very high, over 90%. The other very important messages you will see from current major guidelines, APASL guideline, ASD guideline, and the ESL guideline, they introduce additional antiviral intervention during late pregnancy for those mothers with higher HBV viral load. Early stage non-randomized controlled trial by Professor Han in China, they reported their result by terbinafine further reduced the incidence of new baby for infection HBV to zero nearly in their small study. After that, tenofovir instead of terbinafine, lamivudine becomes the first line antivirus for not just for clinical standard of care, but also for further reducing mother-to-child transmission of HBV infection. You will see from WHO guideline for prevention mother-to-child transmission that introduce a lot of innovations at the basis of pyramid benefits, the largest number and are necessary for those at the top of pyramid to be effective. For there are still challenges for this area, not just opportunity, such as 3 dose is mentor for reducing new incidence of HCC by mother-to-child transmission, but coverage is still not expected as us. Universal administration timely birth dose in the first line of defense against perinatal infection for all infants, but not so timely in some of regions in our area. Also, for tests, HB recommended in many high-income countries in China, but there are supply issues in other areas, such as Southeast countries. Antiviral treatment can make a difference for few women with a high HBV viral load. WHO will release their new HBV guidelines tomorrow morning. So we hypothesize that we have additional antiviral invention could be possible bring to a new era for nearly zero transmission of HBV infection to our baby. We set up this program since 2015. We hope in future with a generation free of hepatitis B, we publish our dream in Lancet Infectious Disease. Here is the whole design of our program. First stage pilot study, mother with the HBsAg positive voluntarily to participate in this pilot study from 10 hospitals across China. We introduced the invention procedures for inpatient, also database captured by APP centralized. When we start this program, additional antivirals not yet introduced into our guidelines. Stage 2 for implementation, again, surface antigen pregnant mother voluntarily join our program from 178 hospitals across China. Stage 3 for scaling up all surface antigen positive mothers in Bao'an district of Shenzhen. Shenzhen is a big city next to Hong Kong. It's an economic dynamic area. A lot of population move to there from developing area. We developed a managed algorithm on preventing mother-to-child transmission, published this algorithm in English version in clinical gastroenterology and hepatology, also Chinese version. There are 10 key steps. Furthermore, we use web-based APP and mobile health tools for managing of our participants, not just the surface antigen pregnant woman, also 1,500 more doctors from different departments for set up a system for counseling, for education, both patients and doctors, and electric medical recorder, and whole course of management. You will see, by using this web-based APP, we connect doctors and patients with this new platform. You will see beside me is a very junior doctor. She managed over 300 more surface antigen positive pregnant women. Previously, she is a doctor in his hospital based in Fujian. A lot of interactive with patients, with doctors from different hospitals and different departments. By this collaborative network for prevention mother-to-child transmission across China with nearly 200 hospitals and clinics, we set up a system also with some 10 more sites as an excellent basis for training medical staff for prevent mother-to-child transmission linked to integrated triple elimination program by government. Let me show you further why we choose Bao'an district for community scale up. This area has a good representative with a surface antigen prevalence rate of 8.79% among pregnant women when we started the program. Furthermore, a lot of new immigrants from other developing provinces to this district. The other reason is this district was designated as one of 6 pilot areas for elimination mother-to-child transmission in China by government. It has a shared technical team appointed by government in this hospital. We set up an e-clinic integrated of infection management and the obstetrics service. 11 key steps linked together. We provide a one-stop service. Any of mothers test surface antigen positive in this area will enter our electric system. Also, we link our program to integrate PMTCT program, prevent HIV, syphilis, HBV for mother-to-child transmission, get support from local government. Here we'll show you further stage 1 with 1,000 surface antigen pregnant mother at 10 hospitals, stage 2, over 30,000 surface antigen pregnant women enrolled, and stage 3, over 8,000 surface antigen positive mother in Bao'an district included in the study. Here is the overall result from our program. You will see we suppose around 5% of mother-to-child transmission. In first stage, we find that around 0.9% transmitted to their baby. Stage 2, stage 3, both of them are 0.23% transmission. It's much more lower than WHO expected additional target by 2030, 2%. Here is a baseline characteristic, stage 1, stage 2 voluntarily, so more patients with E antigen positive, stage 3 all surface antigen pregnant mothers in the study. So a quarter of them are E antigen positive. And HB vaccine and HB coverage is extremely high, over 99%. For stage 2, stage 3, patient, according to our algorithm, we call the compliance group, will extremely lower mother-to-child transmission in either overall population or high-risk population defined as HBV viral load overall equal 5.3 international unit in second, third trimester. Similarly, in Boan district in stage 3, we had done some further subgroup analysis in stage 2, published this data interim analysis in Nature Medicine. You will find our results show that regardless of region, type of hospital, levels of hospital, local GDP per capita, in 2018, age HBV were low, HBAG status in MSV procedure during pregnancy, mode of delivery, and breastfeeding, MTCT rate was consistently lower. WHO recognized this program, also gave us a lot of support for this program. Ladies and gentlemen, here is my conclusion. Shared program provides successful experience and real-world evidence in implementation of comprehensive innovation for prevention mother-to-child transmission. Transmission rate are very low across different settings. I hope this experiments in China will help our region to further eliminating mother-to-child transmission in future. This work already published in February issue 2024 in Nature Medicine as a cover paper. Thank you for your attention.
Thank you, Professor Hao. Well, anyway, congratulations of the great success of the SEALD program.
Thank you.
Okay. Is there any questions from? Yes, please.
Thank you, Professor Ho, for your excellent talk. I have two questions. The first one is why Shandong province has a higher prevalence of hepatitis B surface antigen as high as in southern China. The second question, why HBe antigen dropped to 25% in the later stage?
Okay, thank you. To my knowledge, until now, we do not have exact reason for relatively high prevalence in South China, such as Guangdong, Guangxi, Fujian, Jiangxi, Hunan. All these areas with relatively high prevalence of HBV infection. Fortunately, this gradually declined recently. More recently, several governments, Fujian province, Guangdong province, just kick off new program that do universal screening of HBsAg positive age between 20 to 17 in general population. In future, we will show more results from this relevant data, such as Fujian province, lowest area is around 5%. High one is 9%, much more lower than previously. This is first. Second question, you mentioned about, oh, sorry, some thoughts in my, sorry, could you repeat the second question?
Why HBe antigen decrease?
Yeah. Could you go back to the slides with table and figure for me? One reason is, first stage, pilot stage, second stage, implementation stage, all of them are not all surface antigen mothers in their region or their hospital selected, so they are more e-antigen positive. In Shenzhen, Bao'an, is real life, real data. 25% is a whole cover nearly 100% of surface antigen positive mother in this Shenzhen Bao'an district. Thank you.
Okay. Yes, please.
My name is Thuy from Vietnam. So my question is that whether in China the testing of pregnant women for HPV infection is covered by the government?
Yeah.
Thank you.
Covered by government for vaccine, for HPV, for free injection, for test of HPV surface antigen. Yeah, free of charge.
Any other questions? I'm very glad of your success, and it will extend to other areas in Asian Pacific region. And then, by the way, are you planning to do some project treating the HBs antigen positive mothers? Do you have any project for the mothers who are positive for HBs antigen?
Yeah, there are, you mean predict for outcome? Sorry, could you repeat predict?
You can find many mothers who are positive for HBs antigen. And are you planning to do some treatment for those HBs antigen mothers?
Okay, great. That's a very good idea. Currently, we are doing a screen mother benefits the whole family project based in Shenzhen. So in future, we hope we could pull together our data to analyze the data to help to further improve the outcome of mothers, particularly for those we treated with short period for prevention purpose, not for treatment purpose. Thank you.
Okay. Thank you very much. Time is coming for.
Thank you. Thank you very much.
Thank you very much, the lecturers and moderators.